As we mentioned in the prior post, here are two full-thickness macular holes by OCT, and we ask if you will consider the same approach in each one. Let's dive in. So both cases are from female patients above 60 years of age. Case A was initiated 3 weeks ago with metamorphoses and decreased vision in the left eye. The case B, she doesn't know exactly when she started with the symptoms, but she believes everything started about 3 months ago. So now to the OCT. What are we looking for? What we need to check in this OCT? So case A shows a medium macular hole based on the IVTS classification. That, in terms of detail, considers the narrowest or more proximal point in an horizontal line at the opening of the macular hole. Here we also see cystic hyporeflective spaces around the hole, and we usually don't do this in practice, but if we consider the base hole and the height of the hole, we can calculate something that is called the macular hole index. Additionally, we have a small active area of BMT. Now, case B has a medium hole by IVTS classification, but look at the height, which is smaller. Also, we don't have active VMT. We can even see the posterior alloy above the macular area. So we have two very different cases of macular holes characterized by OCT. The most important factor to take into consideration is the active vitreomacular traction. This is very important to take the next step in the treatment. So the gold standard treating macular hole has been partial vitrectomy with internal limited membrane peeling, air fluid exchange with long-acting gas tamponade. But there is also the possibility of another approach, which is called pneumatic vitreolysis. Pneumatic vitreolysis, or PVL, has been described since 1993, and numerous studies have emerged showing an average range that reaches up to 86% for closure in macular holes, especially in those not chronic, small, and at stage 2. Based on OCT characteristics, we decided to start with PVL in case A, and for case B, we propose partial vitrectomy and PVL to our patient, but she refused surgery, so we start with PVL. Here is the outcome. In case A, 1 week after the gas injection, the inner retinal layers closed well, and at 1 month, all retinal layers were completely restructured. The vision improved to 20/25. Also, we can see a complete separation of the posterior alloy. Case B, at 1 week, nope, no closure, but we see a significant size reduction, so at this point we decided to move for pars-plana vitrectomy and ILM peeling. She underwent the procedure with no complications. So important pearls from these two cases. PVL can be a good choice for treating macular hole, especially for those in stage 2 or with active VMT. Pars-plana vitrectomy is more suitable for those who have no active VMT, larger holes or chronic holes, or for those who are at risk of retinal detachment with peripheral lesions. If you want to consider PVL as the initial approach, always check the periphery to rule out any lesions. It is essential to mention the need for head posture, face down, and drinking beard maneuvers during the first week in PVL. Thanks for watching.